Good morning and welcome back to my lecture series on pulmonary hypertension. Pulmonary artery catheterization will demonstrate the pulmonary vascular, pulmonary hemodynamics, and whether the pulmonary circulation is reactive to vasodilators. Measurement of vasodilator responsiveness should be performed with a short-acting vasodilator such as inhaled nitric oxide, inhaled prostacyclin, and intravenous prostacyclin or intravenous adenosine. Measurement of pulmonary artery pressure, cardiac index, and right atrial pressure can be used to predict the survival. Other major prognostic factors include the etiology of pulmonary hypertension, functional status, mixed venous oxygen saturation, and evidence of right heart failure. The 6-minute walk test evaluates the functional impairment, prognosis, and response to chronic therapy. In this patient, idiopathic pulmonary arterial hypertension was diagnosed 2 years back when she developed severe dyspnea on exertion and an episode of syncope. Evaluation for cardiac and pulmonary etiology was negative, and chronic thrombotic pulmonary hypertension was excluded by a normal ventilation perfusion scan. She is currently on continuous intravenous prostacyclin and oral sildenafil with class 3 heart failure, that is dyspnea with minimal exertion. What additional evaluation is necessary prior to surgery? Assessing the risk and benefit of surgery. In the face of increased impedance to RV ejection, the right ventricular ejection, the compensatory reserves of the right ventricle are limited. Reduction in right ventricular volume, stroke volume, and cardiac output occur, eventually resulting in ventricular interdependence with decreased left ventricular filling. Anesthesia and surgery may produce additional increases in PVR and decrease in the right ventricular function, resulting in progressive hemodynamic deterioration and death. Patients with pulmonary hypertension have markedly increased morbidity and mortality with anesthesia and surgery. Mortality is as high as 70% in patients with Eisenmenger syndrome undergoing the cesarean section. Patients undergoing liver transplantation have mortality rates as high as 80% when the mean pulmonary artery pressure exceeds 45 mm of mercury. The risk associated with idiopathic primary pulmonary hypertension appears to be even higher than those related with secondary pulmonary hypertension. Survival in patients with pulmonary hypertension with the ability of the right ventricle to compensate for the increased PVR as assessed by cardiac output, right atrial pressure, and functional status. These factors also are major predictors of perioperative risk in the surgical patient. Perioperative risk is also related to the surgical procedure. Procedures with rapid blood loss may result in fatal hypotension since the adequate right ventricular filling is required to compensate for increased right ventricular afterload. Major procedures which result in systemic inflammatory response syndrome may exacerbate the pulmonary hypertension. Finally, some procedures pose special risk for the patient with pulmonary hypertension, such as pulmonary embolization of air, bone marrow, and cement during the joint replacement surgery. Risk assessment requires the balancing the functional reserves of the patient against the anticipated increased demands of the surgical procedure. In patients who pose an unacceptably high risk, consideration should be given to lung or heart-lung transplantation or to chronic treatment to decrease the pulmonary hypertension to acceptable levels before surgery. In general, oral calcium channel blockers are used for patients with a positive vasoreactivity test and prostanoids, endothelin antagonists, and PDE5 inhibitors, that is sildenafil, are used in patients who either do not have acute vasoreactivity or fail the calcium channel blocker therapy. The patients initially had class 4 heart failure from her pulmonary hypertension. 3 months after treatment with continuous intravenous prostacyclin and oral sildenafil, she had significant improvement to class 3 heart failure and has remained stable since her improved functional status was confirmed by a 6-minute walk test of 304 meters. Her pulmonary artery pressure were 95/60 prior to starting the therapy and 78/42 on therapy. Her echocardiogram 1 month ago demonstrated moderate right ventricular enlargement and moderate right ventricular systolic dysfunction with an estimated right ventricular systolic pressure of 80 mm mercury. She was therefore considered to be at markedly increased perioperative risk, including the effects of pneumoperitoneum and associated carbon dioxide absorption intraoperatively and diaphragmatic dysfunction postoperatively. However, based on her 2 recent episodes of acute cholecystitis and her inability to increase cardiac output in response to sepsis-induced vasodilatation, the decision was that the surgery was inevitable and that her risk with emergency surgery far outweighed the risk of an elective procedure. Preparation for patient for anesthesia and surgery. Prior to anesthesia and surgery, patients with pulmonary hypertension should have an electrocardiogram, chest X-ray, arterial blood gases, and echocardiogram. Evidence of significant RV dysfunction should prompt the evaluation of the need for surgery. Patients receiving chronic therapy for pulmonary hypertension should continue on such therapy throughout the perioperative period. Patients on chronic prostacyclin infusions should have the infusion continued throughout the perioperative period, and patients on chronic inhaled iloprost should receive a treatment prior to surgery. The patient's prostacyclin infusion was switched to a hospital infusion system by an experienced nurse. She received her morning dose of sildenafil in the preoperative area. Anesthetic management. The anesthetic management of patients with pulmonary hypertension undergoing non-cardiac surgery is controversial. Most authors agree that the way a specific anesthetic technique is managed is as important as the choice of the technique. In the absence of evidence-based recommendations, anesthesiologists should focus on the hemodynamic principles. Now I come to the end of this session of my lectures. Rest of the information I will come with my next video. Thank you.